Welcome to Adapt NCLEX. Board exams can be very difficult. And one of the frustrating issues with this new generation NCLEX is a bunch of lab works. Let's make this easy. I'm going to show you how you can weed through the noise when they give you lab work and make it easy, what you need to focus on to answer the question. So let's get through it. This is a short presentation. And this is what I want to tell you. Labs are there for a purpose. When you see a lab, review the labs in the context of the case. Key fact, number one, review it in the context of the case. Don't focus on the details. Number two, just find the abnormalities in those lab work. Then use it to confirm your diagnosis from the case you already read. Lastly, use it to rule out other disease process, basically rule out other disease process. What it means is when they give you a bunch of lab work, look at it, go through it quickly, focus on the things that will let you rule out the information, and then confirm that this diagnosis I'm picking is consistent with the lab work they've given me. You can't pick a diagnosis that is not consistent with the lab work. And you use that lab work to rule out other things. You don't need to know the lab work. They're going to give you the reference range in the case form, and then they will tell you what the patient lab is. You just compare it and see if it's this higher or low. That's why you don't have to memorize the lab work at all. They will give it to you. I'm talking about case study. This is all case studies. The other thing you have to know, in medicine, this is exactly what we do. We order lab to do the same things I've said before. Rule out things, pick out the diagnosis, and figure out. The doctors, when they suspect a diagnosis, they order labs to confirm that diagnosis. That's why we have what we call differential diagnosis. I know these three things may be a problem, so I'm going to order certain labs to rule out and rule in. That's all. Rule in or rule out is what the lab work they've given you. Don't worry about the number they give you. So let's use an example. I just want to use an example. If they give you example, okay, this is a specific example. 18-year-old female in the emergency room with anorexia, okay, nausea, but no vomit, low-grade fever for 2 days, and right lower quadrant pain. You know there's a bunch of things you should worry about, right? Your differential is based on what you think is going to happen. What do you think is going to happen to this patient? This is a female in the emergency room with anorexia, does not want to eat, has some nausea, does not want to vomit, low-grade fever for 2 days, and right lower quadrant pain. You have to have certain differential. This may be your differential diagnosis is what? Appendicitis, at least appendicitis, at least ectopic pregnancy. Okay, that's big. These are the biggest one. Or maybe nephrolitis, but that's lower on our differential. What do you think the nurse will do or the doctor will do? What do you expect? So the doctor, if I suspect, my number one is appendicitis. Okay, I suspect appendicitis, right? Right. I suspect appendicitis. I suspect ectopic pregnancy. I'm going to order certain labs to rule out. Okay. So what do you think we're going to do? We're going to order CBC. What are you looking for in the CBC? I'm looking for WBC. That's all. H does not matter. Platelet does not matter. But I will tell you, your WBC, you want to see whether it's high or low. They will give you the reference number, and then it will go up. Usually 11 to 4 to 11,000, right? Expect it to be high. That's all. You don't have to know the number. So they will give you 16,000, 18,000, 15,000. Yeah, it's high. H, that means hemoglobin, don't even look at it. Just look at it briefly if you think it's appendicitis. Okay, if it's appendicitis, I just look at it briefly and see if it's normal. When it's normal, I know that this has to be appendicitis. If the platelets, sometimes when you have inflammation, it goes up, but you should expect it between like 150 to 450,000. Like I said, don't boil too much normal. This is normal. So for somebody who has appendicitis, all I care, I look at the CBC, I'm looking at the WBC and see if it's high. If it's high, I move on. That's all. And I said, I write this on my board. The board they give you said WBC is high, so I think it's appendicitis. If the patient you suspect is has appendicitis, expect them to give you urinary analysis. So they will get like a UA. And UA, what are you looking for? There's certain things in your urine analysis that they will give you a pH. Don't worry about it. Okay. They will give you a color. Don't worry about it. Okay. They will give you amount. Don't worry about it. Okay. The things that can go wrong with appendicitis is because of the ureter, the way the anatomy is arranged, the anatomically, physiologically, the kidney ureter that connects the kidney to the bladder run where the appendices. And so they may have some sort of inflammation. So they may have like some white cells in your urine. Okay, that is expected. It's an expected finding telling you that, oh, this may be appendicitis. So don't be surprised when you see some white cells, some mild white cells in the urine. But you should not see, if you see some small bacteria, it's okay. But no too much bacteria. No, that means this is a UTI. You see what I'm doing? If they give you many bacteria, you worry about. If they give you many WBC, you worry about this UTI. If they give you blood, you know that this may be some kidney problem. Okay, if they give you protein, yeah, this is also a kidney problem. So it's not appendicitis. So you just looking at those numbers to just rule out. So somebody with appendicitis, as you see some mild white WBC in their lab work, that's all. I should not see many bacteria. I should not see many WBC or blood in their UA. And this is what I'm looking for to rule out things that I know this is not the problem. Okay. And that's the first thing I want you to focus on, right? Then they may give you BMP for appendicitis, BMP. Guys, you see sodium, you see potassium, you see CO2 for acidosis, you see creatinine, you see BUN, and glucose. Glance at them carefully and just move on. What you need to pay attention to, every time they give you a BMP, look for potassium. Make sure it's normal, because when the potassium is normal, it's abnormal, things go bad. For somebody with appendicitis, I'm looking for BUN and creatinine level, right? So for us, it's normal, I'm good, because this patient will get a contrast. And so you have to look at it to make sure that it's not too high. If it's too high, they may give you a question that you may have to question it or give some fluid. So looking for those numbers to make sure. If you want numbers, BUN should be less than 20. Creatinine should be 1, at least 1. Okay? No, at most 1. Some people say 1.5, but I want to use the 1 so that the ratio can be 20:1. That's all. And your K, make sure it's greater than 3.5 and then 4.5. That's all. That's where I want it to be. Appendicitis, what am I looking for? Normal K, and make sure the BUN and creatinine is normal so that when I'm ordering a CT scan, I can make sure they don't have nephropathy. The same thing, because they're not eating, the creatinine is not that high. That's all. Now, if you think, okay, if you think before that, if they give you CRP, that is basically inflammation. It's just showing you inflammation. It's an inflammatory marker. And they give you normal that is high, don't boil on it. No, don't boil on it at all. So don't boil on it, don't worry too much. What it means is C-reactive protein, that's all. Usually it's less than 3. That I said the normal does not matter. It tells you you may have some inflammation going on. So if they give me a case with appendicitis, I look at the lab work, I look for the white cells, I move to the UA, make sure there's a small little white cells in it, but nothing more. Then I say, okay, it's appendicitis. I look at the BU and creatinine, make sure they're normal in case I need to get a CT scan. But most of the time, your BMP is going to be normal. And if they give you CRP, C-reactive protein, it's an inflammation marker. It's supposed to be high. And then you're done. You're done. Look at the case we are presenting to you. Okay, I give you a female. For this female, you need certain lab work. If they give you ACG and beta ACG, you need beta ACG. It's indicated for this patient in order to make sure she's not what? Pregnant. Okay, she's not pregnant. So this patient need beta ACG. If I give you that, you have to make sure it's negative for appendicitis. If it's positive, it changes and everything. So if it's positive, they give you beta ACG for the same patient, you know this become what? Ectopic pregnancy. And therefore, what do you look? Your CBC, they may have mild WBC. So their white count too can be like 13,000 from inflammation or 14,000. Don't worry about it. It's expected, right? But this is the biggie. Your hemoglobin may be low because they're bleeding. So you can see they can give you like 925 or 930. In the female, yeah. In the female, you know, when I see hemoglobin 930, I know this is bleeding. This cannot be appendicitis. Appendicitis should not drop your hemoglobin to 9. It should be normal, like 13, 14. It should not be 9, or hematocrit 30 or 25. When they give me this case and I look at it with leukocytosis and a hemoglobin low, I rule out appendicitis. I said, no, this cannot be appendicitis. This female is pregnant. And the UA, they may have some blood in it because they're bleeding. If they have bleeding through the uterus, yeah. If they have spotting, I'm looking for like the UA to have some blood in it. And this is what you should pay attention to when they give you a lab work. Don't worry too much. Just like go through the weeds and just figure out the key. I pick and say, oh, why can't it normal? Hemoglobin is low. UA, this is confirming my diagnosis of ectopic pregnancy. And then you move on. Don't bother down too much about it. Okay? So that's that portion of it. Now, they can change it and they can make it easy, difficult for you, but they'll give you so many lab work. And like I said, pay attention. Okay, if this patient we think he has nephrolithiasis, what do you expect? It's a kidney stone. Kidney stone, they usually have what? Flank pain radiating to the groin, right? The kidney stone is moving as you move. you can see they shouldn't have white count should be normal. So your WBC should be normal. Okay. When you get the CBC, the H&H, they don't bleed that much. The bleeding is not bleeding. It's just the kidney, small blood in your urine, but it's not actual bleeding. This is going to be normal. When you do a UA, yes. When you do a UA, you should see gross hematuria. So there's a lot of blood in it. Okay. The urine color may look pink. Yeah, that is telling you this is not normal. This is not like appendicitis, or if I see blood, a lot of blood in the lab work, yeah, I know I need to have a pause and suspect that something is wrong. So this is like normal kidney stone. There should be no leukocyte esterase. So leukocytes esterase, there should not be any of them. So, or let's see, nitrate. Nitrate should be negative. I'll explain this to you. Then leukocytes esterase should also be negative. These are signs of UTI. When you see these two, it's bacteria there causing infection. So these are signs. When you see this, somebody with the front pain, with leukocyte esterase, nitrate positive, yeah, think about now the individual as UTI. They don't have just kidney stone. This is not gross hematuria. This is not just blood in your urine, but they have infection. And these patients, like a pyelonephritis, you may see UA, you may see leukocyte esterase positive. You may see nitrate positive. You may see WBC positive. We call it pyrouria, basically. That means there's bacteria in their urine. Yeah, this one, you know that this is the problem. And they may have frank pain, okay, that radiate to the umbilicus. You see, this does not go to the groin. So if that give you a question, I say somebody with frank pain radiate to the umbilicus. When I give you a lab, you should see a leukocyte esterase, nitrate, WBC, and pyelourine in their urine. Okay, when you get a CBC, you should expect the white count to go like high, 14,000. The rest, their H&H should be normal because there's no stone. This is infection, no bleeding. They may have blood in their urine because of the bacterial infection, but they will not have H&H is not going to drop. This should have blood in your urine. I'm trying to teach you how to like navigate through the weeds about diagnosis and what to expect. So this is just a confirmation. So when you study, know what you expect in the lab work and use that to confirm the diagnosis. That's all. If they give you sediments, okay, that's fine. They have UTI, they may have sediment. If they give you sediment for kidney stone here, it's okay. That is fine. Don't worry about it. These are things that you boil down and get confused. Okay, so this is a short question I give you for that so that you can pay attention about things you need to know. Guess what? If we know patient has DKA, you're looking for ketones. That's all. If they have what? Glomerulonephritis, no, nephrotic syndrome. You know there will be some blood in your urine or in the either nephrotic syndrome and acute glomerulonephritis. Yeah, you know what is the inflammation of the nephrotic system. Therefore, this one, blood, your UA, you expect to have blood in your urine, right? There's going to be blood there. Okay, there's going to be protein. That's all. You should not expect ketones there. You should not expect the white cell. You don't expect any bacteria. They don't have that. Okay. So this is the two things that You see it and you say, oh, I think these two things make this diagnosis good. If I see ketone, I'm worried about decay. If I see white cell and bacteria, I'm worried about infection. And you go through the weeds and you said, no, this is what I expect. I'm moving on. Okay? What else? Anybody with abdominal pain, don't forget that they can give you LFT. They give you AST. They give you ART. They give you bilirubin. They give you, those are they will give you albumin also. Just watch for it and say they have to. Like I said, I don't want to give you the normal values because it's not necessary. They're going to give you the range. See if it's normal. This LFT is for liver problems. So I'm looking if all the normals are high, patient has a normal liver issue, except albumin. If the liver problem, this will be low. But if it's a liver problem, I expect AST, ALT, bilirubin to be high, and albumin to be low. It's just telling you the patient has a liver problem. So when patient has cholecystitis, yeah, I should expect AST, ALT to be high. That's all. It should not affect your albumin or bilirubin unless they have stone in the common bile duct, or they have like pancreatitis sometimes due to the stone. Those are the things, you see, I'm trying to tell you, this is how we work out, make a diagnosis to figure out. Okay? If they give you, in addition to this, they say, oh, amylase and lipase is high, then they're talking about what? Pancreatitis. That's all. You don't have to look at the normal. The normal can be a million. It's just telling you, confirming your diagnosis with pancreatitis. That's all. That's all you need to worry about. Does that make sense? I hope it does. One more thing. Cardiac. You're going to see a cardiac question. And they can confuse you. Anybody with chest pain, okay? If you come in with chest pain, we suspected cardiac chest pain, we're going to get cardiac enzymes. Guess what? Your muscle, your heart is a muscle. So they're going to get CK, they'll give you CK, creatinine, what? Kinase. That's the protein in the muscle. So they're going to give you CK, but there's different kind of CK. There's a CKMB. This is CKMB, and then there's a CKBP. Okay. So there's the different kind of CK. All you need to know is they're going to diffractionate it and tell you what which one is more important. And then CKMB is specific for the heart. Okay, this is for the brain. So we don't pay attention too much. The normals is going to be high. The one that you need to worry about is troponin. They will tell you the troponin is elevated. And what they will give you is either less than certain normal, like less than 0.01 or 0.05. They will give you a normal level. If they give you they said the troponin is greater than a certain normal with the reference rate, you know it's a myocardial infarction. The individual is going to get a what? EKG. And they will tell you ST elevation. I'm giving you this because I want to show you something, how they can confuse you. ST elevation. When somebody have chest pain, it can be pericarditis, right? So for myocardial infarction, that is MI, this is the difference. They all have chest pain, right? These people, CKMB is high. Their troponin is high. Okay. Their EKG, which shows either 1 or 2 ST elevation. in the leads. Guess what? If you have pericarditis, troponin is normal, CKMP is normal. There's no tissue dying. Your ST elevation is diffused. The word is diffused. That means every one of them is affected. All of them. Then you can rule out, because if I give you heart attack or pericarditis, I'm going to give you the same thing. I'm going to put pericarditis and I'll say ST elevation, diffused ST elevation. These one are single 1 to 2 leads. So you can distinguish between them based on your lab work and say, oh, I don't think this patient has an MI. It's just there's no troponin, there's no CKMB, and the ST elevation is in diffuse segment. And you can use that to rule out. Okay, so that's what I want you to pay attention to. Of course, they will give you coagulation factors. Like I said, they're going to give you the normal numbers, or they can say high and low. You know some of the things you expect. If you're on Coumadin, yeah, your INR and your PT is going to be what? High than normal. They may give you numbers, you know, you want it to be the 2 to 3 INR, right? If you are not on prosthetic, right? If you're taking prosthetic valve, yeah, it should be 2.5 and 3.5. But like I say again and again, they'll give you a normal and they will give you what is the individual numbers are, and it will be higher than normal or less than what is expected. Platelet may drop, so platelet 150 to 450,000. If it's less than 150,000, it's usually thrombocytopenia. So that's not good. So then you have to do something about it. Somebody on like aspirin or heparin, yeah, you worry about it. PTT is for heparin. Once again, they will give you the normal range and what the individual and what you need to do. The last one I want to talk about is TSH, T4, and T3. Pay attention. TSH and T4 are the main thing you use to see if the individual is hypo, thyroid, or hyper thyroid. The T3 is very short-living, so it usually does its thing and goes away quickly, but T4 lasts longer. So the best way to remember this relationship is the high TSH, okay, and a low T4, not T3, T4, you know the individual is hypothyroid. If they have high TSH, no, low TSH, and high T4, you know this individual is hyperthyroid. And that's all. You don't have to boil it down too much. Look at the numbers, look at which direction, and you can answer the question. Once again, what I'm trying to let you know is when you're doing a case study, give you a bunch of words, make the diagnosis from your case, use the lab work to confirm it. You don't have to memorize every lab work. Look at it and say, is this high or no? Is he confirming my diagnosis? If it's high or low, am I using that to rule out other ones so that if they give you what do you expect this patient have, and I give you a bunch of stuff, you say, oh, it cannot be ectopic pregnancy because his pregnancy test is negative, right? It's appendicitis because he has white count. He has say UA is a little bit bacteria in it, and he has right lower quadrant pain. His HNH is stable. That's all. Then you move on. It can't be pancreatitis because amylase and lipase are the same. They are normal. It can be cholecystitis because his AST, ART is elevated. You can't have appendicitis and your AST, ART is elevated. It can happen, but that's not the normal. They're giving you a normal scenario. So think about it, put it together, and then you can move forward. Don't boil too much. on them because they will distract you. You'll be confusing and trying to figure out what every lab work means. Just look at it, glance through it, try to confirm your diagnosis. That's the purpose they're giving you. They cannot give you a case study without a lab work if there's lab work indicated. Okay, take care of yourself, and I hope this explained everything to you. All the best of luck. Subscribe to Adapt NCLEX if you have not. Check videos online. All the best.